Dr. Britton sets the time, so I assume he'll be at 10. There's 127 questions, so what is that usually? Well, now I
2 hours.
beginning. 2+ hours, so maybe at 9:30. I don't know. 9:30. Okay, and then at 1 o'clock, Nikki Brooks comes in and talks about pituitary diseases.
Yes.
Tuesday is Dr. Britton from 9 to 12, workshop. The afternoon is all Dr. Bonetta. That was after the survey moved everything over to Tuesday afternoon, so you're out of class. Wednesday is your SPBL, right? Yes. Okay. And that afternoon you're out. You're usually out after an SPBL in the afternoon, right? Okay, then Thursday morning is midterm at 9, and I'm at 10 with adrenal and pituitary diseases. And that afternoon from 1 to 4, or whatever time it takes us, are the cases. And then the morning is the debrief, okay? So that's different from what some of you are showing me.
Yeah, it still shows the data online on the Thursday time and the cases
Okay,
on
I'll
Friday.
figure that out. Maybe I have to do something. I must have not done something that links with you all in or the calendar. Okay, questions about that?
No.
Okay. Okay, radioactive iodine. So, it's a treatment of hyperthyroidism due to Graves and multiple other causes of hyperthyroidism. It can be cheaper in the long run than surgery. Probably not cheaper than thioamides, I would imagine. They're pretty dirt cheap because they've been around for a long time. Could be used in poor surgical candidates, people who don't respond to therapy. You can't ever get them euthyroid, or they can't tolerate, or they have a bad reaction. People who develop recurrent hyperthyroidism after surgery, so you didn't get all the gland, or you got too much, your gland is still hyperfunctioning if you did a lobectomy. Contraindications, pregnancy and lactation for radioactive iodine. Makes sense, right? Okay. If you got that severe Graves there's just too many. Myelopathy. Becky Carlozzi alluded to this. She stated this as well, that you would not use it. And people who can't follow radiation procedures, that's probably one of the biggest things. It may be lack of willingness, understanding, how serious they take it. And it gives you some examples. So like a single parent, incontinent older adult. In terms of, you talked about what you say, if you're flush the toilet twice. So things like that. Mechanism of action, it disrupts hormone synthesis. That iodine gets taken up readily. You've got a hyperactive gland. It will readily take up iodine and try to make thyroid hormone out of it. It kills those cells, so they also then dump a lot of their contents out, and that's why you get that thyroiditis or hyperthyroid increase after the use of iodine. 2 to 3 months to see maximal effect. So again, you're just depleting and killing off those cells over time. So beta blockers, so you may give them before and after to control symptoms. The thioamides, you can do the very same, but you have to think about what they're doing. So they're blocking synthesis. They block iodination. So you have to stop them before you give the radioactive iodine, or it won't work. It'll keep the cells from taking it up. So you'll see in there's protocols about how many days you stop it before and how long you wait till afterwards if you're going to use it to control symptoms for a few months or weeks after the iodine. Make sense? Okay, so pre-treat, keep that in mind. Shows you there lower cure rates if with methimazole it's 4 days before, 7 days with PTU. And restarted after 4 days. So you got a period of about a week to 10 days whenever you would use it. Beta blockers, we talked about that using before and after. 60% of patients will become euthyroid in 6 months, the rest within 1 year. Almost all of them will become hypothyroid at some point, so you just keep watching them. And then you replace them with T4, which we'll talk about in the next section. Successful indicators are higher ablative doses. So, makes sense. Females, lower T4 at diagnosis, they're making less hormone, and they don't have a big goiter. So what do you monitor? Free T4, total T3, TSH, 4 to 6 weeks after treatment, and then at 4 to 6 week intervals for 6 months. Again, that is because of that half-life that I erased. Okay. Very notable at the bottom of that, it's over half the clinicians prefer it. It ought to say how many patients prefer it. Physicians probably prefer it because it's quick. It's once and done, and then you're just putting them on. And then there's surgery at the bottom. Treatment of choice if it's contraindication to the use of the other agents. Its subtotal thyroidectomy is effective in more than 90%, so high effective. Got to have a, what did she say about the surgeon? Good surgeon. May avoid, that goes with most any surgery you have. May avoid the risk of hypothyroidism, but there remains a risk of recurrent hyperthyroidism. Hypothyroidism first year. Okay, so it's a permanent change in the gland, risk of surgery, and then they will all be hypothyroid at some point. Okay, so how many would go, so think about it, so you got thiolamides, RAI, or surgery. How many would do surgery? Nobody? Really? Is this like a personal preference? Or
is it
your personal preference?
Diffuse thyroid issue, or?
I don't know. What do you want it to be? It doesn't matter.
If I can take out half, I might just go for that and see if they can implant the
Okay, so how many
parathyroid.
would do surgery based on what you think or what you, okay, you got one.
Yeah,
Radioactive iodine.
if I knew the surgeon, I might just
How many? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Thiolamides? Yeah, that's what I would do. I'd rather take a drug than eat those other two things. Okay, well, interesting. So y'all are about, it's about the same as what we saw in the clinicians preferred. Okay, questions about hyperthyroidism. At the top is a summary. It's just repeating what I've already said, but I do want to talk about the other health issues. So think about it in your hyperthyroid women, is that your skeletal bone turnover is increased, so they are at risk for osteoporosis. This goes also for people who take T4 and their levels are too high, that you're giving them too much drug, or those people who develop a factitious hyperthyroidism. Okay? I don't think people think about it. I think they just think, weight loss. But so rapid turnover of bone, increase, osteoporosis, fracture rate, bone density. One of the speakers talked about that accelerated bone architecture it's just chaotic, and it doesn't lay down a good bone, so they tend to have more fractures. So you get a negative calcium balance. You're taking out more out of the bone than you're putting back in. So you want to have them take an elemental calcium, unless they're hypercalcemic, of course. So 1,200 to 1,500 is a little bit higher than we usually recommend. So keep that in mind. I don't think it's a common link people think about. Weight loss, common feature. So if you cure their hyperthyroidism, guess what? They're going to put on weight. Warn them. So the average is 12 pounds. So make sure they know, and then you can plan. You can say, okay, it may be inevitable. You're changing metabolic rates. So it may be very hard for them to keep that weight off. Thyrotoxic factitious, how do you say that? Factitis? This is where they are taking it for a non-thyroid reason. Weight loss, again, is one of the most common ways that people get this. So again, the very bottom is suspected when the patient presents with symptoms of thyrotoxicosis without gland enlargement or eye changes. Any comments on hyperthyroidism? Okay, let's talk about hypo, very common. Underproduction of thyroid gland. Most common is primary failure. So primary failure is which gland? Thyroid, right. Most common cause is Hashimoto's. So that's an autoimmune. And it's all different degrees. People can have smoldering, long-term, takes years or months, or they never fully have hypothyroidism, but they have just, their TSH just kind of slowly creeps up. So the ability of T4 is depressed because you're killing off cells, so you just don't have as many cells to produce it. So these are the folks that will have antibodies, circulating antibodies. So if you're not sure, then that's an antibody. She talked about the expense of them, not drawing them on everybody. Keep it in mind. So it can also be a result of ablative therapy. So if they've had radioactive iodine, or if they've had surgery. Let's say they had those things and they were normal for a year or so, and so they just quit going to the doctor. Or they transfer, they move somewhere, or they lose their insurance. So they may show up in your office 5 or 6 years later and they're raging hypothyroid. So you might always ask, especially if you saw a scar, or you can ask them, have you ever had a therapy for this? Therapy for hyperthyroidism. Excessive iodine intake, okay? Too much can also be a problem. Some, the thyroid will put out a lot. Over the counter, like kelp and the herbal products, high iodine. People can get hyperthyroid off of it, they can get hypothyroid, they just suppress effect. They're normal, they make enough T4, they'll shut down their TSH. And so the TSH will decrease and their production will go down. They get hypothyroid. So that's the one over the counter that I know is the most, so kelp. I would never be attractive to kelp. I really don't, I just wouldn't do it. But, and I don't know if kelp and seaweed are the same in terms of people using the term. You know, I just wouldn't think about using the supplements. That's what I'm saying. Now, seaweed in a food, it's okay. But people take kelp. I'm not sure what draws them to it. Subacute thyroiditis, iodine deficiency. Rare in this country because we have iodinized salt. Now, that surprises me. You all don't know that. You were taught that in grade school? Really?
We were taught it this year.
You suppressed iodine?
Yeah.
All the other information I'm learning.
I don't know who told me that. Yeah, since yesterday. Okay, so that's why some salt is good. All right, drugs. So keep these drugs in mind. There aren't that many, but when they show up, they can do a lot of problems with the thyroid. Lithium is big. So we talked about that. You might go back and look at that. We'll talk about it on the next page. But go back and pull out your lithium handout, that beautiful lithium handout that I gave you. And it talks about hypothyroidism. It's about 50% of people. Some stay subclinical, but a lot of people get it. Goiter is not uncommon with lithium. Amiodarone, another big one. And it causes 3 different types. Such an interesting drug. The other one I put down there, I do not know how often that cancer drug is used. Sunitinib, I'm not sure. And then interferon A. We don't use it as much. It is an immunosuppressive. You may see it in some cancer regimens. But a lot of drugs have supplanted it because of the side effects associated with interferon. Secondary due to pituitary TSH deficiency, so usually an adenoma, so maybe a surgical or ablative therapy or destruction to the pituitary. If you got pan-hypopituitarism, then we'll talk about that next week. Tertiary hypothalamic deficiency, I have never seen that, so I'm not sure what causes that. Or peripheral resistance to the action of thyroid hormone. I think that's low and rare, but is a possibility. So clinical presentation, that little guy on the side gives you a pretty good picture of it. And it's insidious. It usually occurs fairly slowly over time. Some people may not notice it. Cool, rough, dry skin. They're cold intolerant. So that would be 100% of women if you went by just that. Puffy face and hands, constipation, weakness. So you see that muscle weakness here, and you also saw it with hyperthyroidism. Menstrual abnormalities, menorrhagia. So that might be something to work up in a young woman who comes complaining of that. Infertility, another one. It's just part of the workup of infertility. They usually can't get pregnant, stay pregnant. Other organ effects, the thyroid hormones have lots of effect on receptor density, especially beta receptor density in the heart. Okay? So if you've got low thyroid hormone, low beta receptors, then bradycardia can be significant. Low cardiac output, so heart failure. Slowed respiration. So you can just see a slowing of everything, right? And with hyperthyroid, it was an increase of everything. And it becomes pathologic on both ends. Inability to concentrate, lethargy, fatigue, depression. Children, here's these two be particularly aware of. As far as I know, they still test all newborns for thyroid, which is one of those things that's easy to do and then prevents bad things from happening. Children, retarded growth. We talked about hyperthyroid. They have rapid growth. So retarded growth, short stature, precocious puberty, declining school performance. But newborns. So newborns that are born with low thyroid, they develop a problem called cretinism. So if you've ever heard it used derogatory, cretin is usually someone of low IQ. He's a cretin. Well, it's a derogatory term off of that. Mental retardation, short stature, respiratory difficulty, jaundice, poor feeding, retarded bone maturation. So that's the newborns. They're routinely screened for hypothyroidism. Early can prevent mental retardation, but you have to start it quickly. If you go a few months, their neurologic development will be so impaired that it will impact their intellect. That last statement is also important. Babies who are euthyroid but born to hypothyroid mothers can also have diminished intellectual development. So monitoring that, talking to the mom. So the primary thing you'll see diagnostically will be a low T4 and elevated TSH, right? So the pituitary, if it's intact, it's just going to keep telling the thyroid, put it out, put it out, put it out, because that negative feedback is not coming back and telling it. So all the pituitary knows is, there's not enough T4 telling me to do anything differently, so I'm going to keep pushing out TSH. When to treat? Well, if their TSH is greater than 10, look back at the number on page 4. What's the normal range? TSH?
4.5 to 12.5.
TSH, 0.4 to 4.5. It's one of those that's kind of good to kind of keep in mind. I usually think about 1/2 to 0.4. Still all the decimals. For patients now, there is a group called Subclinical Hypothyroidism. This is a big controversial group. Do you treat them? Do you not? You will see as people get older, their TSH will go up. So there's big controversy. Do you treat older people with it or not? because does it change outcome? So we'll go through that a little bit about who to treat. But that's called subclinical hypothyroidism. If they come in with symptoms related to hypothyroidism in that range, then the current thought is treat them. If there's no symptoms, then usually they'll hold off. There is one vitamin that you need to keep in mind and ask about, which is biotin. What do we use biotin for? What? Hair, skin, and nails. The RDA is like 2. What do women usually take?
A ton.
3,000 to 5,000 a day. This vitamin interferes with the assay for TSH. So it can make it look elevated, or if they're taking it, sometimes not taking others. So it's good to have them off of it when you assess their thyroid. So it's an assay interference, not an error. It doesn't change what the thyroid's doing or what the drug's doing or their hormone levels. So what we're going to do is we're going to replace their thyroid hormones and make them euthyroid. Same thing as hyper, euthyroid, that's what we want. So we use a synthetic thyroid hormone product as the drug of choice. So levothyroxine is drug of choice. Thyroxine is T4. It is available in a wide variety of generics. The brand names Synthroid and Levothyroid have been around for a long time. A lot of companies, insurance will not pay for it anymore. I know my insurance company won't pay for Synthroid, they'll only pay for generic. So drug of choice, it gives you, it's only T4, so it's relying on peripheral conversion, and for most people that is not a problem. So they can convert to T3 in the periphery, but for whatever, whatever the demand of the body is. Half-life 7 days, so that dictates how often we measure TSH. So most people will go out 5 to 8 weeks, somewhere along in there. Now, there are drugs that we designate should not be therapeutically interchanged. So what we would prefer, because some people can be very sensitive to small changes in thyroid. So if you switch brands, then you could have a change in availability, bioavailability, just in the availability of the ability to absorb out of that dosage form. So we encourage patients, once you're placed on a product and you achieve a euthyroid state, try to stay on that. The problem comes with the generics. So it used to, you could stay on Synthroid forever. And now that the insurance companies won't pay for it because of the cost, what I do is I take generic levothyroxine. I just ask the pharmacist, always make sure I have that generic brand. And if you have to change, then I need to know. And if I'm going to have to make a change, I never have a TSH drawn around that time. I always wait until I'm stabilized out on it before I make a change. So that's for very sensitive people. And honestly, I'm not that sensitive. But that is one thing I would think about. Have you been, if somebody is all over the place, first thing I'd be asking is, do you take your drug? I'll admit, I know it has a long half-life. So if I'm nowhere near having to have a TSH and I skip a dose, I don't worry about it. That's bad. I know kinetics. So, but I'm giving you some things. First, always, if people are not responding to any treatment you ever give them, adherence is number one. Number one reason why people don't respond. Okay? So this would be one of the things to ask. It'd be one of kind of a little bit down the road. Well, okay, have you changed brands? Have you changed sources? Would be one to think about. The dose. Now, yesterday, Becky Carlozzi said, you know, usually you start in this range and then you make clinical decisions about whether to change. Okay, I'm going to give you the reasons behind the clinical. What do you use? So, there is a dose. Now, the reason why most people can say it's, most women need between 88 and about 125. Okay? So, it's based on weight. It's 1.6 to 1.7 micrograms per kilo per day. Okay? If I'm a good shepherd, you come out and you say, okay, they're on 200 milligrams, they're micrograms of levothyroxine. I'm like, what is that in milligrams per kilo? It's usually based on ideal weight. So that's why, again, most of the time, so if you didn't want to know anything and you go 88 to 125, that's usual, but there is a reason behind it. It's a microgram per kilo base. It doesn't matter if you use 1.6 or 1.7. Ideal weight is the best predictor. Now, she talked about this yesterday. Let's go through it again. Young, healthy adults without cardiac effect, you can start them on full replacement dose. So if you all came in, most of the time we would put you on a full replacement dose. The people who you would not do that to are cardiac patients. She alluded to that. Because think about it. If you put them on full replacement dose, you are revving up their metabolic rate, they will get angina. I saw it at the VA all the time. So starting older patients and people who have cardiac disease, even if they have subclinical, if they have subcardiac disease, if you suspect that there probably is cardiac disease that's subclinical, I would start low. There's nothing to, it's not going to hurt. Okay? So starting with 12.5 to 25, I would only start 12.5 in somebody who's really had advanced cardiac disease. So 25 to 50 is a good place to start, and you go about every 2 weeks and up the dose by 12.5 to 25 until you get to the end, or whatever the dose you're shooting for. Okay? That is why when she said in cardiac patients you start low and you titrate up. It's the cardiac. It's that metabolic rate. Subclinical hypothyroidism that do not require a full replacement. So if you're in that range of 4.5 TSH to 10, those folks usually need about 75. What did I put?
25 to 75.
Yeah, so 25 may be a little bit too low, but you can certainly start there and check their TSH, especially if they're not that elevated. So somewhere in that range. So keep those ranges in mind. Subclinical do not need full replacement. They still are putting out because their TSH isn't that high. Their T4s are usually at the lowest end of normal, low end of normal. Okay, got those? It's weight-based. Cardiac makes a difference, age makes a difference, subclinical hypothyroidism makes a difference in terms of the dose you choose. You check TSH every 4 to 8 weeks because of half-life. You can advance the dose faster than that if you're dealing with a cardiac patient. So at the VA, what we do is we would start them on usually 25. I did see people get increased chest pains on 25, and then in 2 weeks we would tell them, then they could go up, whatever we had a schedule. So 25 to 50, stay on it for 2 weeks. If you're not having trouble, you can go up to 75, and then whatever our end dose was. She did talk about those incremental changes of 12.5. Those are really sensitive people when you can't make a 25 microgram change. Overtreatment, rare. I have seen people at the Good Shepherd at over 200 micrograms a day. I'm telling you, most people rare. Even the biggest man usually does not need more than 200 micrograms. So when you see that kind of high, I would really be asking, now tell me about that. How did you get there? How did that happen? I just want to hear their history. Could be non-adherence, titrating up against non-adherence. So overtreatment, again, worried about AFib in older people, and we're worried about that accelerated bone loss in postmenopausal women. All right, the thyroid on an empty stomach. So that is the recommendation. Mostly minerals are going to tie up thyroid, calcium, iron, most commonly. So you do want to separate it out if you have that kind of content in a diet or in a meal. But for most people, getting up and waiting an hour, you're just going to see if that works. 30 to 60 minutes is the recommended. Personally, I wouldn't tell somebody to get up in the middle of the night when they're up and take it. There are studies that have looked at people taking it with before a meal, with a meal, after a meal. And in the people that they did, the TSH did go up in those who were taking it with food, but it didn't go out of normal range. It didn't go out of range. So, I take mine with breakfast. There is no way I can get up I can't even think an hour before I eat. So, I always do it, but I'm very consistent, and I eat about the same thing every day. So, to me, that's consistency. I don't drink milk with it. I don't take any iron. I don't take a vitamin with it at all. And I'm pretty much I'm in about the same range anytime I get tested. So, but if you have people who are very sensitive, or they cannot, or they can't avoid certain foods or drugs that they're taking, then that hour in between is very important. The other is they could take it at night, but they'd have to have 4 hours since they ate. So that might work for some people. So it's true, if you can get people to take it on an empty stomach, great. I would always have a conversation with them. Does that work for you? Yep, I don't eat till noon, it's great for me. What other medicines do you take? Great, okay, that may work. But if they can't, it's better that they take it every day and you titrate against that, and that will work as well. Okay. If you can't get them stabilized, then another thing would be is go to empty stomach and see if that works better. Okay. So lots of tablet strengths. Usually the tablets are color coded. It's kind of like Coumadin. If you take this strength, that's the color. So that's another way. I used to keep those cards that she showed you, the picture of all the thyroid. Did I do that in here? I don't think I did, but she put it up there. I just keep it in the office, and it's like, okay, show me which one you take. If you can't tell me the strength, show me the color. Now, if they're colorblind, I just had to call the pharmacy, but that's another way to check. There is an injectable. We'll talk about when that's used as well. Once the person becomes euthyroid, unless they're doing something odd or some disease takes in or they add a drug, they're usually going to stay pretty stable on it. If you see wide variations, then they're missing tablets, probably, is what I would look at. Or they've gotten something new that's interfering. They got put on iron and they start taking it with it. So look for those big interfering substances. Dose reduction with age. So once they get over 60, 65 is probably the time where you would start to really pay attention. Dose is more than likely going to go down. Yes?
Above that, on goals of therapy, to CSH within normal limits, 0.4 to 2.5. Should that be 4.5 or is it lower?
Oh, it's probably 4.5. Okay. It's a typo. Thanks for catching that. See where he's talking about? Okay. So checking every 4 to 6 weeks until you get them euthyroid. Then you could go every year if you want to, as long as they're stable and they understand. Okay, adverse effects. Over replacement is the biggest problem. Drug interactions, things that tie it up. So if they're on a bile acid sequestrant, if they're taking Bieta, remember one of the GLP-1s, it slows GI transit. So it's one of the drugs you really have to separate out. If I had someone on thyroid, I would switch them to a different GLP-1 because the other ones don't interfere. Drugs that increase clearance, so carbamazepine, anytime you've got a seizure medication, they are always going to mess with the other drugs, always, always. So having a pharmacist who can help you sort that out, doing some reading on yourself about how to space things out in terms of a drug will be very helpful. You're like an annoying younger brother who can never leave you alone or stay out of your room or not bug you. They're always going to be in your hair. So keep them in mind. Drug interactions, huge, because they're almost always 3A4. They're almost always inducers or inhibitors. Okay. Other hormone replacement products. So there is a T3. She talked about it. The problem is short half-life. It's only T3 and the cardiac effects are much higher. Most people don't use this. But occasionally you will see folks on it. It has to be given 3 times a day, so it's more of an adherence problem. And it costs more. Liotrix is one to keep in mind. It is actually a T4-T3 combination, but it is in the ratio that your thyroid produces it. So if someone had trouble with conversion or they just needed that little bit of T3, this might be a drug to consider. It also is more expensive. I would only reserve it for people who I didn't think were converting very well, or you didn't get a good response out of T4. Okay, the desiccated thyroid. So the armor thyroid. So if somebody talks about armor thyroid, that's what they mean. So it's from animal source. It is not a clean drug in that you've got other substances that can interfere. I'll give you my personal opinion on it. There's kind of a new groundswell of people who want to go natural. So they want to go natural with another animal's organ thyroid. So that is with some people. I don't want to take something that's synthetic or created in a lab. Okay, I would never put somebody on it. Never. It is there's too much variability. It really is hard to stabilize them. The other thing is several years ago they just ran out. You couldn't get it, so you had to convert a lot of people. That hasn't happened that often. It wouldn't be the only reason why I wouldn't do it. It's just harder to standardize people on them. And I think that the T4, I think with synthetic T4, it's just pretty much perfect for most people. That being said, you may run into people, I still would see folks who were started on it as a kid and they've been on it all their life and they're doing fine. Leave them alone. I wouldn't advocate starting somebody on it. The American Thyroid Association doesn't recommend putting people on it as new, but people are doing fine, I'd leave them alone. So that's my opinion. It's inexpensive, and it shows you there it contains T4 and T3. So you may get some side effects from the T3, but it's a pretty small amount. Comments? Anybody have a different opinion on that? I'm happy to hear it.
Is Nature-Throid another one?
Is
that
what?
Would be Nature-Throid, would that be the same as armor? I mean, similar.
I don't know it.
Okay.
I don't know it.
The practitioner used to work for a lot of people. It was WP, and then I think
What
like
are they?
What is this one called?
They're like armor.
Okay.
They're like the
They're desiccated
Yeah,
thyroid.
it's like from pig thyroid.
Then I would say I just put them all in that category.
And last year, armor thyroid, Nature-Throid, Westby thyroid, WP thyroid all went off the market because they had to revamp their manufacturing to standards. It was awful.
Okay. Do you see a lot of people on outside of armor? Do you see a lot of people on those others? Really?
I've seen
Who
a lot
is
of
putting them
patients
on it?
others too.
Who is
Their
doing
primary care. I think a lot of them came from their primary cares.
Okay. Okay, special conditions. Myxocoma. So this is life-threatening. This is long-standing, uncorrected hypothyroidism. This is end-stage bad. Okay. Clinical symptoms, hypothermia. These people their metabolic rate is so low they can't maintain normal function. So you see the delayed deep tendon reflexes, puffy, so they're edematous. They have a really yellow kind of waxy coating to their skin. Cardiomegaly, peripheral effusions, dementia, not a good state. Precipitating factors, what puts them in it? Change in weather, stress, diabetes, other diseases, hyponatremia, diuretics, respiratory depressants. So the treatment is interesting. Here we use IV T4, and we use big doses. Look at the dose, 400 to 500 micrograms. Big doses. So what we're doing is we're trying to saturate those binding sites first, so that we can then get their free T4 to go up. So we do that for I don't remember how long. And then we take their dose down to 300 micrograms daily until they can take PO. We do not put them on that dose PO. Okay? We'll convert them over to a lower dose and titrate them to effect. Okay? So there is an IV T4, just to be aware of that. If you're in myxedema, coma, they'll be in the ICU. Convert them, and then we'll get their, we'll switch them and put them on oral T4. Okay, pregnancy and infants. So some particular things in pregnancy. She told you the other day, depending on what trimester the woman is in, she will have different goals. Okay? When she becomes pregnant, her dose immediately will have to go up. In fact, what they'll sometimes tell a woman is that, especially if she's planning a pregnancy and they know that, as soon as you got a positive pregnancy test, increase your dose. So a common way, an easy way, is to have them, if you're taking it daily, then go up to 9 tablets a day, 7 to 9. An easy way to do it for them at home. The TSH values, if you look under number 4, specific for trimester. So first trimester, it's 1 to 2.5, 0.1 to 2.5. Next is 0.2 to 3, and then 0.3 to 3. You do not have to know those values, but you've got to know that you have different values, target values in each of those trimesters, and that you have to increase their dose, usually by about 25 to 30%. So it shows you there, first missed period, first positive pregnancy test, up the dose. Optimize thyroid status before they get pregnant. Drill that into them for the health of the baby. Won't hurt them so much, but it will the baby. Hyperthyroidism. A lot of women get hyperthyroid during pregnancy. PTU again is preferred if you have to treat it. And then switch them over to methimazole. It does, that last one's important. It will cross the placenta, so it'll affect fetal thyroid. So what they do is they keep the T4 high. So they keep it, you'll see there it says maintain T4 level just above the upper limits of normal. And then they're going to monitor frequently, every 2 to 6 weeks. That protein, that binding globulin, gets really affected by levels of estrogen. Estrogen levels go up, then that binding protein also goes up. So that you're going to monitor more often because of that.
Do you do the same with hypo in pregnancy, monitor more frequently?
You do, because you're in true trimesters. I don't know. I'd have to go back and look. What did I say?
I missed it, but I don't see where it says.
At least once a trimester, as you're going to change dose and your goals change. So I would do it at the end of each 12 weeks, at least. Page 18, congenital hypothyroidism. Levothyroxine is your other choice if you have to use it. Note the dose, about the same, a little bit wider range, 12 to 17 mics per kilo per day. Gold, keep the T4 in the upper range of normal. Breastfeeding, remember methimazole you can use in breastfeeding women. You needed to? One thing we do in breastfeeding is that we try to dose the drugs around the time of the feedings. So if I breastfeed and then take the drug, the child doesn't get any exposure. They would get some the next time I fed them, but it would be in a lower amount. Okay? So when we get to lactation next module, we'll talk about that, how we space drugs around a feeding. So we can use that to our advantage. Here's lithium, our old friend, concentrates in the thyroid gland, interferes with thyroid hormone synthesis. So you inhibit those synthesis, TSH rises, it keeps pounding the thyroid gland, gets bigger. So most people are going to have a goiter. And this can happen in up to 50% of people. Not everybody will have a goiter, but the risk is high. A lot of people will have subclinical hypothyroidism, so keep that in mind if you're treating manic patients or bipolar depression, where lithium is often used. Usually will happen early in the first couple of years. If there's a goiter, then it's recommended again that you would scan it and you would do a needle aspirate if you needed to establish a diagnosis. You can use T4 to replace them and keep them on the lithium. This will often happen. Get a history. Is there thyroid disease in your family? Get a baseline. And that may help you identify people. Some even will do antibodies before to identify who is at risk. Amiodarone, really important because it's so common, especially in older folks. So hypothyroidism, 2 types of hyperthyroidism. Again, the hypothyroidism, you can get the other thing, I'll come back to that first part, but the second one is it inhibits conversion from T4 to T3. It's one of the few drugs it does. Remember the beta blocker, propranolol also does that. So the hypothyroidism, I saw this a lot, at least in the Coumadin clinic where we had a lot of AFib patients. 6 to 10% can occur anytime, doesn't matter the dose. Most of them are going to be on about 200 to 400 a day. You can leave them on the amiodarone. Usually the cardiologists don't like to take it off, especially because it's a good drug, it controls well. But you can use T4. If you take them off the amiodarone, then you'll probably have to take them off the T4. Keep that in mind as well. And remind patients. Well, patients will usually remember that. If they can come off a drug, they'll like, you told me when I stopped this drug, I could quit taking this. Amiodarone-induced hyperthyroidism. This one is sudden onset. Thyrotoxics, they would have the same thyrotoxic symptoms that others have. Type 1 is the iodine load, huge amount of iodine. If you look back up to the top, it's 12 milligrams of free iodine, so you don't have to buy it, but you are buying the drug, so it isn't so much free, for 400 dose. I'm kidding. Okay. Okay, so lots of iodine per tablet. Because it's free iodine, it says it's free iodine, but I'm making a play, you're having to buy the drug. So it does cost you, but the iodine is just available. Sorry. Close to lunch. So the other is type 2. Now this is more of a thyroiditis. It actually will destroy the thyroid cells. And so there you can use like a steroid. So if you look at type 1, so you're giving it a lot of iodine, so you're going to use a blocker. So use methimazole or PTU, just to block synthesis. Probably a lower dose is going to happen with most people. Type 2, beta blocker for symptoms, like you would with any thyroiditis, and steroid to cut down on the anti-inflammatory effect. Last one, interferon, is mostly, well, you get it with both. Hypothyroid up to 45%, so again, a very high amount. So here are the people most at risk, women, but most women are on, well, I shouldn't say that. Women, Asians are most common, those on interferon, think about the hypothyroidism. More common than hyper. Hyper is 10 to 30%, it's Graves-like a presentation. Similar to a thyroiditis, like you see with amiodarone. Use beta blockers if they are symptomatic. They don't get permanent changes, so most of the time with these three drugs, they will go back to normal when you take it off. So that will be the other thing, is removing the drug and remembering to take them off of it. I love the thyroid, it's so easy. Compared to most things, it's a fairly easy drug to work with. Okay, we will come back and we'll see Dr. Brand at 1:30 for imaging. You'll like him, he's a really good teacher. He's worked with me.
34.